All right. Good morning, good afternoon, good evening, everyone. Excited to see you all. And it is Neurology Morning Report. So we have A, who will be discussing, and Bayan who will be presenting. I think everyone knows everyone, and we have to stop at 9 because there's another virtual morning report this morning. So with that in mind, let's go ahead and get started. Bayan, do you want to give us the chief concern?
Yes, and just to pace ourselves, I have 4 or 5 aliquots depending on how we split things.
Okay,
So our
for
chief
sure.
complaint is a 71-year-old female presenting with altered mental status. I can stop here or give you more.
Um, that's okay. Let's stop here. So A, how do you think broadly about altered mental status? We don't have too many details, but just your broad framework.
Yeah, with altered mental status, as you have taught us about that, we will have differentials for like neurology causes or psychology causes and other systemic causes. For like neurology, we have a lot broad differentials like affecting the brain, for sure. So it can be infections, like autoimmunes, or for infections like encephalitis, meningitis, and also into autoimmune encephalitis. And also there could be like brain abscess, and it could also be like it presenting for like seizures. We have to make sure that how the automated status is presenting. And then could be any like neurodegenerative causes, dementia related, and then trauma, any structural lesions like hematomas, SDH, EPH, like brain tumors. And we also have to differentiate like any primary psychiatric causes and other systemic causes like toxic metabolics and drug related. So it could be due to hypoglycemia, any like hypernatremia, and then maybe due to drugs, like illicit drug use. So we have to make sure any like drug history with any illicit drug history. Yeah, that is the one that keep in my mind.
Brilliant, fantastic, A. So that's perfect. Yeah, altered mental status. I know amongst the CP solvers community, the MIST, NMIST is popular. All due respect to the NMIST mnemonic, if that's your preferred mnemonic. I think for me, the mnemonic, well, one, I'm not much of a mnemonic person, but I think it also sort of takes away some of the, or it doesn't account for some of the important clinical reasoning aspects, particularly the time course. So I agree with A. Yeah, when I think of altered mental status, my broad buckets are exactly as she said. Is this medical, so a systemic cause of some condition that's causing what I jokingly call bad humors, right? Liver failure, renal failure, toxic metabolic conditions that cause some bad humors, and the brain would be okay, but it's sort of bathed in bad humors. So systemic, neurologic, as A mentioned, many neurologic possibilities, obviously having to do with the brain if it's altered mental status. And then psychiatric causes of altered mental status. So medical, neurologic, and psychiatric are the broad buckets. And then NMIS sort of accounts for a lot of those. But as I said, it sort of doesn't account for time course. So yeah, I think medical, neurologic, psychiatric. And so of course I'm reading the chart, seeing the medical history, seeing the medications and labs and all those things, whether the patient has any neurologic or psychiatric history. And then also, then I'm superimposing this on time course. So with altered mental status, this won't be a challenging localization case, right? This is going to be in the brain if the patient has altered mental status. And then I'm wondering, is it sudden in onset? And then I'm worried about, could always be toxic metabolic medical, but just thinking neurologic specifically, as A said, is this something related to ischemia, hemorrhage, or seizure post-ictal state? If it's acute, but not sudden, thinking more, as she mentioned, about encephalitis, meningitis, types of infections, immune-mediated conditions. And then if it's more subacute, chronic, wondering maybe about focal mass lesions in the brain, a tumor or metastases, and more chronic, thinking about neurodegenerative conditions. So that's how I think about it. Different perspective than the then the missed and missed. Everyone has their own way of thinking of this, whatever works for you and helps you have a framework to drop when you see this very common chief concern in the hospital, very common reason for neurologic consult. But for me, I think about it just as A does. You can see we're both neurologists. We think about it the same way, rule out medical, rule out psychiatric. And then if we're in the neurology sphere, then we're wondering about the time course, hyperacute, acute, subacute, chronic. Okay, so those are the things we're going to be tuned in for here on the HPI. Great discussion. And we think about this exactly the same way. So let's see how we think about the HPI. Go ahead, Payan.
All right, those are such wonderful thoughts. So, when she's presenting to the ER, she's unable to give history. She's confused and screaming. It seems like she's in pain, but we're not sure where this pain is coming from. And the history was obtained from her son, who she lives with, because she was unable to give us some history. So he mentioned that one day prior to her presentation, she had developed a mild fever, nausea, and headache, and she eventually had 2 episodes of vomiting. Her son did not feel like this was an emergency, and as this developed during the night, he thought that he would take her to urgent care in the following day. During the middle of the night, however, she woke up crying and screaming. Her son tried to calm her down, but she was confused and uncooperative, which prompted him to bring her to the ER. For her review of systems, she has subjective fever that was unmeasured at home. She had nausea and vomiting, as I mentioned, as well as a headache. She has been irritable for the past week, but her son is unsure of what is the cause. At one point, she did tell him that she was having some back pain, but she has advanced dementia, so he's unsure if that is really the cause or if that's not the case. And then for her past medical history, as I mentioned, she has advanced dementia, but she's not on any medications. She has type 2 diabetes and hypertension. She takes metformin, sitagliptin combination pill, and amlodipine, and she's compliant with her medication because her son makes sure that she takes them. She also has a non-specific arthritis. He was unable to tell us exactly what type of arthritis it was, but she was on prednisolone, 10 milligrams OD, for roughly 10 to almost 10 years. Uh, Again, she's compliant with that because her son makes sure that she takes the medication. About a month ago, or less than a month ago, she broke her right ankle going down the stairs, and she had bilateral cataract surgeries 5 years ago. She's not known to have any allergies. Her family history is unremarkable. Her immunizations, her son was unsure of them. As in her childhood immunizations, she had not gotten any immunizations in the past few years. Her social history, she's a retired primary school teacher who lives with her son and his family because of her dementia. She does not smoke, drink alcohol, or use any illicit drugs. I can give you the exam or stop here.
Let's stop here. Okay, lots of information. A, what are your thoughts?
Yeah, for someone presenting with like automated status and fever and headache, common things common, and we have to think the most important differential, which is like infectious cause of the encephalitis or meningitis, and then with she also has underlying dementia, so that could also be worsening of any neurodegenerative causes of that dementia. And I will also think like autoimmune encephalitis or things like that when somebody present with autoimmune status, or she present with some irritation or some psychiatric symptoms as well. And so for autoimmune encephalitis, like NMD receptor encephalitis, because I'm writing case description articles and also helping in like book chapters, writing someone presenting with like acute neurologic symptoms. So these kind of autoimmune encephalitis also came to my mind. And yeah, so other like systemic, we have to rule out other systemic infections, like malaria, also like cerebral malaria, and it can also be other like due to vasculitis, and vasculitis and other like CNS related disorders. And I'm also wondering, like, she's taking prednisone. The prednisone can also induce like kind of psychosis, but it will be like in the under my bottom list of differentials. So at first, I will rule out any infectious cause of like encephalitis meningitis, and then will rule out like any autoimmune encephalitis or things like that. Yeah, it wouldn't be like any seizures or um, epilepsy, but we still have to rule out with like any EEG or things like that.
Yeah, excellent. Let me ask you this. So you mentioned infections here with the fever. We have to think about infection with the history of being on prednisone. We have to worry about infection. The patient is immunocompromised. And then you mentioned autoimmune encephalitis. What's usually the time course for autoimmune encephalitis? Is it sort of hyperacute, acute, subacute, chronic?
Yeah, it's kind of like subacute. Anyone presenting with
Yeah.
kind of psychosis less than 3 months
Yeah, very good. So
presentation.
does this case seem like the right time course for autoimmune encephalitis or?
Yeah, not that much.
Not that much. Yeah, it's pretty fast. Yeah, everything has to begin sometime, right? But to get this sick this quickly, um, yeah, maybe a little bit fast. This is sort of more in the acute time course. So yeah, I'd be thinking more along the lines of infection. You also mentioned this patient has dementia. Could this be worsening of the dementia? Does that usually happen this time course or?
Um, yeah, as you have mentioned, like some kind of like chronic diseases, they are like progressing, but as long as like when you like fall down from the table or
Yeah.
it present with like acute onset. So that's the only possible way. But most of them they are like slowly progressing and
Yeah.
yeah.
Yeah, very good. Yeah, yeah. Most dementias are pretty slowly progressing. The neurodegenerative dementias or vascular dementia, pretty slowly progressive. They can have acute worsening if there's an underlying infection or, sorry, superimposed infection or other systemic insult, a hospitalization. Um, just the change in environment can disorient patients and they can get acutely worse. But yeah, it's said, I don't know if this is where this comes from, but what I was taught and what I also teach, though I haven't necessarily found a source for this, doesn't mean it doesn't exist. But yeah, for example, Alzheimer's dementia, the most common neurodegenerative dementia, people say that they lose about 3 points on a mini mental or a MOCA per year to give you a sense of, about how slowly progressive these things are. So just changing over days here would probably be fast um, for progression of dementia. Though, as you mentioned, yeah, sometimes patients really sort of fall off a cliff quite quickly, and we work them up for all kinds of exotic things, and turns out maybe for whatever reason their dementia got worse on a more rapid time scale, or after a surgery, the patient wakes up and is much worse than before, and it's not always entirely clear what's going on there. Maybe just the brain in the state of dementia is more susceptible to these insults and can have some acute um, worsening. So we do see that, but it's not always clear what it means. But I agree with you. Before we would say maybe that patient's dementia is just getting worse. There's a lot to evaluate for or rule out here, and the number one thing being infection. Um, now, the patient has dementia, so their mental status is not normal at baseline, but this is an acute change. Um, and older patients of this age, even without dementia, but especially with dementia, are at high risk for delirium or altered mental status um, from a systemic insult or a toxic metabolic cause. Um, and so probably most common in practice, you mentioned meningitis, encephalitis, it's neurology morning report. Those are the things on our mind. But when you see these patients in the hospital who are 71 and have dementia and have altered mental status and fever, in your experience, roughly, what proportion of them have meningitis, encephalitis, a new neurologic etiology, and what proportion have a UTI, a pneumonia, some systemic insult that made them look like this?
Yeah, it's really quite few for like meningitis and encephalitis. Most are with a lot of underlying diseases and complications and with just systemic metabolic causes.
Yeah, I agree. That's my experience as well. We often get these consults from our medical colleagues where they say, the patient's older, they have dementia, they have a UTI, but gee, they look so sick and they have fever and they have altered mental status. Is this meningitis, encephalitis? Do they need a lumbar puncture? And lumbar puncture is a pretty benign procedure. And often we say in neurology, if you've talked about a lumbar puncture and thought about it for long enough, probably you should just do it and make sure. But in my experience, these almost never end up being meningitis or encephalitis. And so if there's a clear systemic source, not sort of a soft call on the UA, we don't necessarily subject these patients to lumbar puncture, but if our medical colleagues say there's no clear source, then of course we need to look. Or they seem sort of sick out of proportion to the systemic insult, but most of the time it's more of a rule out than a rule in. That said, I heard about a recent case of a patient who had an ear infection and took a lot of NSAIDs for the pain and developed a renal failure and GI bleeding from the NSAIDs and presented with altered mental status in that context and had fever and had ear infection and had headache and had altered mental status. And no one really thought it was going to be meningitis because the patient had so many reasons for altered mental status, had a very supple neck, and the patient had bacterial meningitis. And it was one of those where it was fever, altered mental status, and we thought because of the ear infection, and you can get sort of meningeal spread from the ear. When there's a bacterial ear infection, you can get meningitis that way. We thought just to be sure, it never ends up being meningitis, just to be sure. And that patient had a colleague of mine said maybe the neck was supple because the NSAIDs reduced so much inflammation that there was no meningismus. But yeah, a lumbar puncture is a benign procedure, and when you're unsure, often we get it. But in my experience, like yours, usually it's a rule out in this context, and it's pretty rare. We learn about bacterial meningitis and herpes encephalitis for the STEP exams, and they're sort of represented as common conditions, but in the setting of vaccines, we don't see them very much anymore. And I've only seen a small handful of cases of bacterial meningitis and viral encephalitis. There's parts of the world that don't have access to vaccination, or not all patients do, and then you see it much more commonly. Another reason here where we would definitely, we would certainly strongly consider a lumbar puncture is that this patient is on prednisone, right? So this is not just bacterial viral encephalitis that's on the table, but this is also all sorts of opportunistic infections now, right? Fungal meningitis, for example. This is a little fast for fungal meningitis. Usually it's a little more subacute, sort of weeks, but and tuberculosis also. So this patient is at risk for a lot of infections. We're talking a lot about lumbar puncture, not that that's the first test we would do. We want to examine the patient, get some imaging, see if there's another explanation here. But yeah, for all the fever, altered mental status, headache cases we see when we say, I mean, there's a UTI or there's COVID or there's pneumonia, probably you don't need a lumbar puncture. This is one where, we don't know if there's a systemic source yet, but even if there was, we might say, gee, with that prednisone on there, I don't think any of us would be comfortable sort of just clinically saying this is not some type of infection. Of course, if the CT shows an abscess or something like that, or strokes, then we might revisit that. Yeah, just to put it out there, another thing, we always say fever, headache, altered mental status, we think meningitis. Another condition to think about is endocarditis, right? If there's fever from endocarditis and then septic embolization to the brain, causing strokes, can cause altered mental status. Mycotic aneurysms developing from septic embolization to the cerebral arteries with rupture could cause headache from subarachnoid hemorrhage. And then you can seed the meninges from bacterial endocarditis. There's a syndrome called Austrian syndrome after someone named Austrian, not the country Austria. That's strep pneumo, pneumonia, endocarditis, and meningitis together, that triad. So, okay, so we're very worried about CNS infection because it's Neuro VMR, but also because we don't know of any other systemic sources. There's some nausea here, but we don't have any other things pointing to a systemic infection. And probably even if we found one, we'd be pretty seriously considering looking for a neurologic infection also. Okay, anything in particular on exam? It's very hard to examine patients who are confused, altered mental status. What are the main things you're trying to sort out, knowing this patient's not going to be able to participate meaningfully in our usual exam, counting fingers and following commands? How do you approach examining a very confused patient? What are you trying to get out of the exam?
Yeah, first, so I just have to like examine any like just any specific portions. So for like cranial nerve, we can see any like reflexes from the pupils, and first, we will look his mental status, and then see any reflexes from like pupil reflex, any like in the motor system, if we cannot access power, we will examine like reflexes and plantar to see any focal lesions. Um, yeah, there, there are only a few tests we can examine on the confused patient.
Yeah. So depending on whether the patient is just confused or actually also somnolent and not awake when we go in the room. Yeah, I agree with A. Our main goals usually are to try to see if there's any focality at all. And if the patient's not going to be able to follow commands, just observing them from the bed when they move spontaneously, are they moving both sides the same? If they make a facial expression or if they grimace to a mild painful stimulus like squeezing the finger at the nail bed, do they grimace symmetrically? A lot of stuff we can test. So the mental status, usually we just sort of are going to describe the patient is awake and confused, or the patient is awake and alert but inattentive. We could, if the patient is asleep, do they arouse to voice? If not, do they arouse to loud voice? If not, do they arouse to noxious stimulate, to light touch, just touching them, or to noxious stimulation, such as sternal rub? These are sort of gradations of how somnolent the patient is. These terms like stupor and encephalopathy, we use them, but they don't always have a clear meaning. Even the Glasgow Coma Scale, though it has a clear meaning, there's a lot of ways to get to 8, depending on what the patient looks like. So I always find it more helpful when I'm writing a note. I hope people find it helpful, but certainly when I'm reading a note, to just say the patient is awake, alert, inattentive, or the patient is awake and confused, not following commands, or the patient has eyes closed but opens briskly to normal voice or to loud voice, or patient does not respond to voice but to light touch, or patient does not respond to voice but grimaces to noxious stimulus. That type of description tells me the state more than saying the patient is somnolent or stuporous or in a coma or something like that. Okay, so that might be the extent of our mental status exam. Is the patient awake? If not, how do we wake them up? Can they follow any commands? As A said, even if the patient can't follow commands, we can test the cranial nerves through reflexes, the pupillary light reflex, the corneal reflex, things like that. And then we can actually even test the visual fields, even if the patient can't count, through something called blink to threat, where you bring your hand from the side quickly on each side and see if the patient blinks. That's not the corneal reflex unless you accidentally touch the cornea. Don't do that. And don't touch the eyelashes. But you're not touching, you're just giving a visual stimulus that's quick and seeing if the patient blinks to threat. And then for the motor and sensory, if the patient won't participate and they're not moving spontaneously, we do a little bit of nail bed pressure, a pinch, and see if the patient withdraws, the same on both sides, showing that they can feel it and they can move. If they don't withdraw, we don't know if it's that they can't feel it, that they can't move, or both. And then you can check the reflexes and looking at the for Babinski sign, as A said. And then in this patient, probably we'll want to assess for meningismus. It can be very hard in these older patients. They often have osteoarthritis. This patient has some diagnosis of arthritis, and so they may have a stiff neck from arthritis. And probably many of us have not seen enough bacterial meningitis to know what that real meningismus feels like compared to kind of just a stiff neck from osteoarthritis. So a little hard to know what to do with that in this age group. We didn't talk much about the non-specific arthritis. If the patient has osteoarthritis, then not much to say about that in this case. Probably someone thinks there's inflammatory arthritis, which is why the patient's getting prednisone. Just in the spirit of neurology, what I call neurology of X, there's neurology, there's stroke, seizure, dementia, neuropathy, et cetera. And then there's neurology of X, like neurology of cardiac disease, neurology of the pregnancy and the postpartum state, neurology of rheumatologic disease, et cetera. In the spirit of neurology of X, A, for example, if this patient had rheumatoid arthritis, any particular neurologic complications you're familiar with that can occur in rheumatoid arthritis?
Why arthritis? Yeah, there are a lot. Maybe like if spine is affected and it's compressing the spinal cords or other like peripheral nerve. I can only think from like peripheral nervous system aspects, not from the CNS.
Yeah, for rheumatoid arthritis, the main complications are spinal. From arthritis of the spine, you can get compression of the cord, you can get compression of the roots, you can get C1, C2 atlantoaxial instability, which can be very dangerous for the spine. And depending on the angle of how things play out, you can even get brainstem compression. But patients with rheumatoid arthritis can also get a pachymeningitis, a meningitis affecting the dura, an inflammatory meningitis, and rheumatoid vasculitis, which could in principle cause stroke. I'm not sure how often it actually affects the brain, but I've seen maybe one case of the rheumatoid meningitis, a patient with known arthritis who'd had chronic headache and had meningeal enhancement on MRI. So an inflammatory meningitis is possible. This is probably fast for that, so I would still be more worried about infection, especially given the prednisone, but just making sure we've squeezed some possibilities and teaching points out of everything that's been transcribed here. Okay, so we're looking to see the patient's mental state. The other thing I should mention is when we say altered mental status, all of us sort of think delirium and this kind of general state where the patient's confused and inattentive. It's important to try to figure out if this is truly a general encephalopathy. Encephalopathy means sort of brainopathy, right? Just that the brain is not feeling well, right? It's not a very specific term. Is this a generalized encephalopathy where the main mental status deficit is inattention, where the patient's not oriented and they can't really say the days of the week backwards and these kinds of things? Or sometimes we get consulted for confusion, altered mental status, delirium, encephalopathy, and actually the patient appears confused because they're aphasic. Or they appear confused because they have amnesia. So is there some focal cognitive deficit here that is causing the general state of confusion, but it's not a generalized brain process, it's a focal process where the patient sounds confused because they have Wernicke's aphasia, or they sound confused because they're disoriented because they have amnesia. So those are possibilities also, and that would change our thinking here if we thought this was a focal problem rather than a more general state of encephalopathy. Okay, so we'll want to get some understanding of the true mental status. Is it a generalized encephalopathy, as is seen in many toxic metabolic causes, but can be seen if there's a diffuse bihemispheric process? Or is it something more specific, aphasia, amnesia, et cetera? And then is there any meningismus? And then is there any focality? Those are the things we'll be keyed in for on the exam. Okay, Bayan, what did you find on the exam?
That was such a rich discussion. On exam, she was uncooperative. She was very difficult to examine, and her son was stressing on the fact that she seemed in pain. He said she looked in pain to him, um, to the point that you mentioned about patients being not actually confused, but just in pain or amnesia, I believe you mentioned. So her son was, repeatedly saying, my mother looks in pain, she looks in pain. And the ER physician did seem to agree with that. And she was started on paracetamol IV to try to calm her down so we could examine her better. On general look, she seems like a typical elderly woman in pain. Her vitals, her temperature was 37.9, that is 100.2 in Fahrenheit. Her heart rate was borderline at 100. Blood pressure was 152/89, and her random blood sugar was 109. For her head and neck exam, she did have neck stiffness. She had positive Kernigue and Brzezinski's sign, but then we were not really sure. The ER physician is the one who did this, and then when we examined her again, they did not seem that strong, and it felt more like she was trying to push away anyone who was touching her rather than actually performing those specific movements. For her cardiac exam, she had a normal S1 and S2 with no additional heart sounds. Pulmonary exam was normal. On abdominal exam, she had specifically tenderness to superficial palpation in the right lower quadrant, to the point where she, again, started screaming after calming down a bit, and she didn't want to be touched anymore. And based on her son's observation and the thoughts of the ER physician, and her not responding to acetaminophen, they started her on morphine, after which she really calmed down, and it seemed like she really was in pain, and that was helping dull the pain a bit. After that, we were able to examine the CNS. So her mental status, she became alert and oriented, but only to person, which seemed to be her baseline. For her sensory exam, she was intact all over, except to the abdomen, which she refused to let us examine. And for her motor exam, she was passively intact in the upper limbs bilaterally and in the left lower limb, but she refused to let us touch her right lower limb. Like even if it seemed like you were coming close to her abdomen, she'd like swat your hand away and become really distressed. So we didn't want to distress her further, so we didn't try to further examine the right lower limb or the right lower quadrant of the abdomen. But on inspection, it seemed like it was fine. There were no rashes, no, petechiae or purpura or any discoloration. On the back, though, we did find a vesicular rash. I can stop here, or I can give you some of the routine labs that we got.
Nope, that's great. Let's stop there. Okay. What do you think, A?
Yeah, with the vesicular lesions, we're dealing with herpes infections. And then, but with the right lower quadrant, is there any like lesions in the like right lower quadrant abdomen? Like, as she is a female, I will think like some of ovarian tumor or things that can present with my autoimmune encephalitis, but the but we can also think other like structural lesions in the right lower abdomen, and she has also like kind of meningitis signs. So is there any like systemic infection with presenting with encephalitis or meningitis, or are these two separate causes? I'm not sure.
Yeah. A rare instance where both A and I, neurologists, are going to be talking about the non-neurologic parts of the exam because there's nothing really localizing here. It sounds like if we're understanding correctly, the right limb, as far as we know, is not weak, just the patient in so much pain doesn't want to move it. And Bayan made a very important point here, right? That sometimes encephalopathy or delirium can be entirely due to pain in this age group, or particularly in patients with dementia, where they can be very confused, and the trigger may not be the systemic cause per se, but actually pain, and that with adequate treatment of this patient's pain, that their mental status improved significantly, such that we could get a more detailed neurologic exam. So what do you make of this vesicular rash? You mentioned herpes infections. Any infection in particular?
Okay, it can be herpes, like other herpes simplex virus, and then chickenpox, varicella zosters, and other like other herpes like CMV. I don't know, maybe also like herpes virus.
Yeah, herpes virus group. And this one being in a very specific spot, unilateral, kind of on the right mid to lower back. Any particular one of those you would think of the most? Which herpes virus causes this very focal rash?
um,
It was one of the ones you said, yeah.
Herpes simplex virus, HSV1 and 2.
Yeah, HSV1 and 2, HSV1, I think, yeah, can cause meningitis, encephalitis. I think our sores, right, in our mouth are those HSV1, and then HSV2 usually genital
Yeah.
herpes. But which is the herpes virus that probably causing a vesicular rash that's so painful on the patient's back on one side.
Yeah, chicken pox, like herpes zoster.
Yeah, herpes zoster, varicella zoster. Yeah. Right. This sounds like, excuse me, this sounds like zoster rash. Can we link a zoster rash with this right lower quadrant pain and neck stiffness and Koenig and Brzezinski sign, or do you think these are separate processes?
It it can be zoster like encephalitis or meningitis. But yeah, I'm not
Yeah.
sure.
Yeah, very good. Yeah. So going along here until we heard about that rash, we heard there's neck stiffness, Koenig, Brzezinski sign, there's meningismus. So this patient's going to need a lumbar puncture preceded by a scan to make sure there's nothing particular on the scan that would preclude lumbar puncture or that would solve the case in some other way. There is a JAMA rational clinical exam paper on, as you know, these papers, does my patient have ascites? Does my patient have this? Does my patient have that? There's one, does my patient have meningitis? And shows that the Koenig and Brzezinski signs are actually very insensitive, something like 5 or 10% sensitive. So actually not that common in patients with meningitis. They're very specific if you see them, but pretty uncommon. My guess is that in Koenig and Brzezinski's time, by the time patients made it to the hospital with meningitis, they were pretty sick, and by that point had severe meningismus, whereas in the modern era where people have access to healthcare, they arrive pretty early when they have a bad enough headache that they would have for meningitis and don't yet have this sign. But when I've worked in resource limited settings where patients may have less access to healthcare or a long journey to a hospital, A is shaking her head, she has this experience as well. By the time the patients get there, they can have very severe meningismus. So we can't ignore that finding in this case. Whether we'll realize in retrospect it's just the patient's arthritis or not, I think we have to take it seriously. Yeah, I wonder if the painful vesicular rash and this tenderness in the right lower quadrant is zoster, and that dermatome that begins on the back on the right there extends to the abdomen. And you can have zoster sine herpete, zoster without the rash. The patient has the rash and part of this dermatome, but either it's not there yet or sometimes you don't have it. I can still have exquisite sensitivity to touch and very severe neuropathic pain. So it's possible that this patient has zoster and that the right lower quadrant pain, this tenderness is due to pain there, even though we don't see the vesicle. So good for Bayon and her team to make sure the patient sat up so they could see their back, and probably the key to this case. And as A said, there is a neurology to zoster also. It can cause meningitis. It can cause encephalitis. It could also cause vasculitis, infectious secondary vasculitis with strokes. Now, this patient with morphine woke up and was able to talk to us, so there's probably not stroke. There's nothing really focal there unless the right limb isn't just painful, but she had an ACA stroke or something and it's weak also. That was a little hard to figure out based on the limited exam A and her team could get due to pain and confusion. But yeah, I would be worried that this patient not only has zoster of the skin, but has zoster meningitis. And do you know A in the CSF? This is a very advanced, specific, detailed question, but what test do you send to diagnose zoster in the CSF? What type of infectious study?
Like
It's okay if you don't know.
PCR, herpes
Yeah,
PCR.
I'm asking this because it's a little confusing in the literature, because there are some papers and textbooks that will say you need the antibody test, the IgG. And my understanding, having read more about this and talking to people, is that zoster meningitis is an acute phenomenon, and the PCR is the best test for that. But zoster encephalitis and zoster vasculitis are a little more kind of infectious, para-infectious. Certainly the vasculitis, I'm actually, now that I'm saying it, not 100% sure on the encephalitis. In those cases, the CSF IgG for zoster is actually more, I forget if it's sensitive, specific, or both, but more helpful, let's say, than the PCR. So zoster meningitis is an acute phenomenon, infectious phenomenon, where you want to test for the PCR in the CSF, whereas zoster, excuse me, vasculitis is a little more kind of para-infectious, post-infectious, inflammatory, and you're looking for the zoster VZV IgG. in practice, we were unsure. We'd probably just send both of them. But worth knowing that you don't want to just send the PCR when you're worried about zoster infection of the central nervous system, but also the IgG. So before a lumbar puncture, we would get a scan. And so we'd want to make sure we're not missing anything here and that our lumbar puncture is safe. The other thing is, where is that rash? Are we going to be able to get a needle into the back without going through one of those vesicles? And if not, would we think about treating this patient empirically for zoster without risking pushing a needle through a vesicle and pushing zoster into the spinal canal? Okay, Bayan, what did you and your team do next? Some basic labs, which probably you can go through quickly if there's nothing particularly salient. And then I think we'll want to make sure that a scan is okay and know if you were able to do a CSF analysis, if a lumbar puncture looked safe based on the distribution of the rash on the patient's back, or whether you just went ahead and treated this patient for presumed zoster meningitis.
So in the ER, they did actually start her on our empiric treatment for meningitis, that being vancomycin, ampicillin, given her age, ceftriaxone, and acyclovir. Just because the ER physician could not really find any localizing signs that pointed to anywhere else apart from the right lower quadrant pain. They did get an ultrasound of her abdomen because they were concerned that maybe she had appendicitis, given that she had never had an appendectomy before, but that was clear. For her CBC, the only remarkable finding was a white blood cell count of 12.8, that being neutrophils 45% and lymphocytes 40%. Otherwise, her hemoglobin, her platelets, her electrolytes, LFTs, RFTs, coagulation panel, everything was normal. They did get a routine ECG in the ER, which showed atrial fibrillation. Her son said that that was not something that had been mentioned before, but we didn't feel it to be linked in any way to her presentation. For her serologies, she was negative for HIV, hepatitis B, and hepatitis C. We did draw blood cultures, but they were still pending. Her urine analysis was positive for glucose, but otherwise clear, and we did get thyroid studies, but those were normal. And they got a CT head with contrast in the ER. They were not really concerned, as we said, about a stroke, given the presentation of her symptoms, but that's why it was gotten with contrast. But it was unremarkable for any acute changes. It did show some changes related to her dementia and some non-specific lacunar changes, but those were not felt to be related to her presentation. And as I said, because we were suspecting some kind of meningoencephalitis, she was admitted overnight for a possible lumbar puncture and MRI, and she was switched from oral prednisone to IV dexamethasone in the early morning. So this was like day 3 of her symptoms, day 1 of admission. Before rounds, we were paged that the patient was desatting to the high 80s to 90s. She became tachycardic to 120. Her mental status again declined. And so we went to see her like first thing in the morning. On the repeat exam, she was found to have even more vesicles in the right upper thigh and extension of the vesicles over her back. She was started on oxygen. Portable chest x-ray showed bilateral patchy infiltrates, and her maintenance fluids were initially discontinued because this was thought to be cardiogenic. But she was also started on bronchodilators. And I think you know where this story is going, but I can stop here or I can like reveal the diagnosis.
Did you end up doing the lumbar puncture or?
No, when we examined her, her vesicular rash was over the L2, L3 dermatome, and so we felt it was not safe to do a lumbar puncture. But she was started on acyclovir empirically.
Got it. Okay. Yeah, just wanted to see if there was going to be that aliquot or not before we pause. Okay, let's pause. And A, what do you think here?
Yeah, it sounds like vesicles are also growing, so it could be due to zosters, meningitis or encephalitis. But as we cannot do lumbar punctures, but she is already on empiric treatment of acyclovir as well. And So I don't know what is going to be the next step to get a definitive diagnosis.
Yeah, good question. Yeah, we've been talking about trying to get the diagnosis, and I realized as soon as Bayan said this, we should have said in practice also, yeah, this patient, if you're thinking it could be meningitis, even with this rash, while you're sorting things out, you would definitely treat this patient empirically, right, for bacterial and viral meningitis, because every hour delay in treatment of bacterial meningitis, the outcomes are worse. There are studies showing this. So if you thought when this patient came in with headache, fever, nausea, vomiting, and you were working them up and thought this could be meningitis, I don't know yet what's going on, vancomycin, ceftriaxone, ampicillin in this age group or with immunocompromised. This patient is both. Acyclovir, get them started. People ask, will that change the lumbar puncture sensitivity? It will not. The biochemical changes will last, I think, a day or two. The cultures and PCRs will last a day or two. So get your antibiotics and antivirals started before you start the workup. Often we're looking for the diagnosis and then the treatment, but here we start treating even without a diagnosis. So you're right, there's a lot of signs pointing to zoster here. Well, we know the patient has zoster. A lot of signs pointing to why would the patient have multiple things? They have zoster on the body. Maybe they also have zoster meningitis. But this is a common situation we find ourselves in. You can't do the lumbar puncture. You can't get it because of the arthritis. In this case, it wouldn't be safe to do with vesicles over the area. Would be putting the needle. And you're sort of stuck saying we don't have a definitive diagnosis. Are we committing this patient now to weeks of vancomycin, ampicillin, ceftriaxone, and acyclovir because we don't know what we don't know? It would have been nice to get a lumbar puncture, and then when the cultures come back negative, you could say, okay, we can take off those antibiotics. But in some of these cases, we can't get it. And then this question comes up, do we feel comfortable stopping all the antibiotics and just leaving them on antivirals? And these get very difficult where it's already been a couple of days and the patient's doing better. And then everyone wonders, did the antibiotics make them better? But we weren't able to get a culture. Blood cultures are pretty sensitive. I don't know the exact number, but the majority of patients with bacterial meningitis will have positive blood cultures, but not all of them. So we're definitely going to keep on the acyclovir treatment. And I'm curious, Bayan, how you and your team made a decision about the level of confidence you had to stop the antibiotics for bacterial etiologies, because that's always a little bit difficult to decide in this case. Even when your clinical intuition is strong, this is not meningitis and I can stop these, it's not bacterial meningitis, then sometimes still you feel hesitant. The patient got better, you don't have a definitive diagnosis. They looked at the beginning like they could have had bacterial meningitis, and you can stop them and observe the patient in the hospital and make sure they didn't get worse, but it always feels a little scary. You've already given them maybe a week of antibiotics at that point. What's another week or two? These are the considerations that come up. So how did you and your team resolve this case, Bayan?
All right, so we did consult dermatology and they confirmed the diagnosis of shingles by taking a biopsy from one of the vesicles. And the patient was subsequently placed in isolation, but given her rapid deterioration, we felt like it would not be a good idea to continue treating her at our hospital because we were at a small hospital that didn't have all the facilities. She did develop bilateral lower limb edema, rising creatinine and BUN, and a clear picture of acute kidney injury, whether that is secondary to acyclovir or something else. Maybe the contrast from the CT, we were not really sure. I know some people say contrast-induced nephropathy is a myth, but we were having all of these discussions. You know, we had no way of confirming the diagnosis. There was a thought of discontinuing acyclovir. Someone suggested valacyclovir. Apparently, that is not as nephrotoxic, but that was unfortunately not available. And so, given this rapid picture of deterioration, we did transfer her to a larger tertiary hospital for possible further treatment. And over there, they got an MRI that did show meningeal enhancement, and so they confirmed the diagnosis of meningitis. Eventually, the lesions over her back did crust, and at that point, dermatology said that it was safe for a lumbar puncture. And so they did proceed with a lumbar puncture, which was positive for varicella zoster. And her final diagnosis was disseminated varicella zoster, probably thought to be due to her elderly age as well as the immunocompromised state she was in due to the long course of steroids that she was on.
Great. And do you know, Bayan, it's no problem if you don't, was it a VZV PCR or IgG or both, or?
I am not sure, unfortunately.
No problem. And how long after she presented was a lumbar puncture done?
Again, I'm not sure. All of these was
No
relayed to
problem.
me by the residents,
No
through
problem.
their friends who are
Yes,
residents in the other
of course.
hospital.
Yeah, no problem. Yeah. So that's great that you are so diligent to get this follow up. It's always challenging when patients are transferred to another institution or from your institution back to their home institution. And then it takes a lot of extra diligence to go that extra mile to find out what happened and close the loop for yourself in your mind, but you learn so much that way. So I applaud you having done that. So we could all learn and also learn that this is so important to do when you have these cases that are lingering in your mind without closure to try to track down some closure as Bayan did here. So good to know. And did the patient get better with this treatment, Bayan? Were you able to find out?
Yeah, there was a thought of discontinuing treatment, giving her advanced meningitis, her advanced dementia. Her children were, her adult children were in discussion about whether, given her advanced dementia and she seemed to be developing multi-organ failure, whether it was worth it to pursue the treatment and put her through that. But she did seem to be improving on the acyclovir. The antibiotics were discontinued. And so the decision was made to pursue treatment. And although she had a very prolonged hospital course, she was eventually discharged, however, much worse than her baseline.
Yeah. So as A mentioned earlier, yeah, this can happen where patient with dementia develops some systemic, or in this case, even worse for the brain, neurologic condition. And even though they recover from it, they don't get back to their prior baseline because they were sort of maybe more susceptible to brain injury and more difficult to recover with age, even without dementia, but certainly with age plus dementia. Fantastic. Well, thanks for bringing this case, Bayan, and going the extra mile to find out the follow-up so we could have some closure here. We're 2 minutes before the hour, and there's another VMR about to start at 9, so we probably won't have time for Sime's excellent teaching points here. But want to thank you, Bayan, for presenting this case. A, for your excellent discussion. You decided right away this was meningitis and concern with prednisone that this could be maybe not the most common cause of that meningitis. And here it was actually the medicine, right? The rash that tipped us off to this being zoster and then zoster meningitis. So we have maybe 1 minute. Sime, do you want to tell us the most important teaching point or the most interesting teaching point that you took away from today's case?
Yes, thank you, Aaron and A, for the wonderful discussion, and thank you, Bayan, for bringing the case. Lots of great teaching points, but I'll just share one given the time. So the Austrian syndrome is a syndrome that presents with pneumonia, endocarditis, and meningitis. That is something that was very unique today. Everything was great, but this is the teaching point I would like to share, being mindful of everyone's time.
Very good. Thank you so much. And I'm sure everyone will learn a lot from reviewing your teaching points. Sorry we didn't get time with the VMR following us today to hear all of them, but I'm glad you selected that one to highlight. Not a very common triad, but every once in a while you might see it and worth considering. Okay, very good. We're going to do another Neuro VMR. I think it's the 15th. Next week is the American Academy of Neurology conference. So almost every neurologist in the world will be there. About 10,000 neurologists are going to converge on San Diego next weekend. So you won't be able to find any neurologists to do Neuro VMR. Although if any of you are at the AAN, we're going to have a morning report there, a live morning report where A is going to present a case to Valeria, and I'm going to discuss in front of a live audience on Saturday morning at 8 a.m. in San Diego for any of you who might be attending the AAN this year. Come see the case. We don't know what it is. Only A knows. So we'll be learning from her and from Valeria, and always fun to see everyone. If anyone's around, come say hi to us. Okay. Thanks, everyone. Have a nice day.
Thank you all. Thank you.
Thanks. Bye.